We will be reviewing our technique for preparation of bone patellar tendon bone allograft for its use in ACL reconstruction. The author's disclosures are listed here. Here is our overview. ACL reconstruction rates have been shown to be increasing not only in younger age groups, but also in older populations. Currently, reconstruction is a standard of care for symptomatic ACL tears with instability. Graft choices broadly vary by autograft versus allograft and by grafts that are primarily soft tissue based versus bone plug based. The most commonly used grafts currently are soft tissue hamstring and bone patellar tendon bone, or BTB, with its two bone plugs for the femoral and tibial sides. It is important to know that use of allograft is not ideal for every patient. Several large database studies, including data from the MOON cohort, have demonstrated that allograft ACL reconstruction has been associated with greater failure rates in younger and more active patients with higher Marks activity scores, as demonstrated in the graph below, showing the relative probabilities of re-tear by age and activity. Correspondingly, the age of those receiving allografts is increasing, and the activity levels associated with allograft use are lower. BTB grafts, and autografts in particular, have frequently been utilized as a gold standard, especially in high-level competitive athletes. BTB is thought to have better healing due to its bony fixation on the femoral and tibial tunnels. In contrast with BTB autograft, BTB allograft not only allows for this bony incorporation, but also limits donor site morbidity, preserves the native extensor mechanism, and avoids the cited anterior knee pain associated with BTB autograft. Additionally, using allograft may reduce operating time, requires fewer incisions, and may reduce brace use for some surgeons' protocols. Our case involves a 38-year-old female who presented with knee pain and swelling after a fall from a motorized scooter 6 weeks prior. She described a popping sensation, immediate swelling after the injury, and reported ongoing instability. On exam, she had a mild effusion, lacked terminal extension, had a grade 2B with Lockman maneuver, a soft endpoint on anterior drawer, and glide with pivot shift. Here we show the patient's coronal T2 followed by sagittal T2 MRI images, which demonstrate the complete ACL tear with the associated bony contusion pattern of the lateral femoral condyle and posterolateral tibial plateau. In general, indications for use of BTB allograft include skeletally mature and older patients, typically at least 30 to 40 years of age, those who have lower activity demands, patients who have had a prior autograft harvest in the revision setting, circumstances when an autograft harvest is insufficient, those with multi-ligament knee injuries, and patients who prefer use of allograft. We now demonstrate our technique for preparation of a BTB allograft. The goal of our technique is to mimic our autograft harvest for familiarity and efficiency. After examination under anesthesia is performed and confirms ACL rupture, or arthroscopic evaluation confirms ACL rupture, the non-irradiated allograft is opened and thawed in warm saline. The graft is placed on a stack of blue towels on the sterile back table for preparation. The graft is initially measured. The central 1/3 of the tendon is selected. The center portion is marked, and 10 millimeters of central tendon are marked for harvest. The graft is stabilized with clamps. A sharp knife is used to cut the tendon longitudinally, taking care to not converge centrally on either side of the tendon. The bone plugs are measured. We typically aim for a tibial bone plug of 25 to 30 millimeter length and 10 millimeter width, and a patellar bone plug of 20 to 25 millimeter length and 10 millimeter width. These dimensions are marked and we start on the tibial side. An oscillating saw is used to first score and then cut the bone at a 70-degree angle on the longitudinal limbs, and the transverse limb is cut perpendicular to the bone. Then we cut the patellar bone plug. The oscillating saw at a 45-degree angle to the bone is used to score and cut the longitudinal limbs of the plug. The transverse limb is cut perpendicular to the bone, and the blade can be angled to help free the corners. The bone plugs are mobilized carefully with an osteotome, and remaining adhesions are released. The harvested portion is now taken separately. 10 millimeters of depth of the bone plugs is measured. The graft is trimmed to this depth on both bone plugs. A 10mm sizer is used to evaluate the graft size. The graft, including excess soft tissue or bone, is trimmed to fit appropriately through the sizers. After the graft size is confirmed, a single hole is placed in the patellar plug with a K-wire. On the tibial side, 2 holes are created perpendicular to one another. A number 5 ethibond suture is passed through the patellar hole, and number 2 fiber wire suture is passed through each tibial-sided hole. These sutures allow for facilitated graft passage and tensioning. The bone plugs are marked to delineate the bone and soft tissue interfaces, marking the bony surface to face anterior in the femoral tunnel. The graft is laid out and placed in warm saline until arthroscopic or intra-articular preparation is ready for graft passage. Once the graft is passed and fixed on the femoral side with an interference screw, we evaluate the graft under tension arthroscopically through range of motion, ensuring the graft is not impinging an extension. The graft will then be fixed on the tibial side with another interference screw and is re-evaluated arthroscopically. The key steps are listed here. 10mm of central tendon is measured, then cut on either side. The tibial bone plug is measured at 10mm width by 25 to 30mm length and then scored and cut to create a trapezoidal shape. The patellar bone plug is measured at 10mm by 20 to 25mm and then scored and cut to create a more triangular shape. Remaining adhesions are released and the graft is trimmed to fit through the sizers. 1 hole is created on the patellar side with number 5 ethibond suture passed, and 2 holes are created on the tibial side through which number 2 fiber wire sutures are passed. The graft is marked to highlight the bone plugs. We abide by the principle of measure twice, cut once to make sure we do not truncate our graft. Care should be taken to not converge when cutting the tendon. A stack of towels limits violation of sterility on the back table. Our preference is to not use bone crimpers to trim or shape the allograft, as we find these may crush the softer allograft bone. The bone plugs and tendon should pass comfortably through the sizers prior to attempting to pass the graft through the corresponding tunnels in the patient. Post-operatively for ACL reconstruction, some authors have added slight delays in rehabilitation due to longer incorporation of the allograft. Typical timelines for ACL reconstruction rehabilitation are listed here, with the goal of patients returning to full sport at approximately 9 months postoperatively. Young and active patients may have higher risk of graft rupture with allograft use. Allograft is associated with higher cost. Although data is mixed, some studies demonstrate higher risk of infection with allografts, which may be mitigated by treating the graft in vancomycin-treated solution and/or wraps. The type of allograft utilized is important, as data has shown that irradiated allografts have more residual laxity and risk of failure. One study evaluating the regional mechanical properties of BTB allograft examined 10 human cadaveric allografts that were non-irradiated. The patellar tendon graft was divided into medial, central, and lateral thirds and underwent cyclic and failure testing. The authors found that elongation and creep strain did not differ by region. However, the central portion of the graft was thicker and had associated greater maximum load and stiffness than both the medial and lateral thirds. Furthermore, the central region maximum stress was greater than that of the medial third. This study confirms that the central third of the BTB allograft is optimal for harvest location, given its thickness and superior biomechanical properties. In addition to utilizing the central third of a BTB allograft, other properties, as demonstrated in this systematic review of 48 studies, may afford better biomechanical allograft strength. The authors found that for soft tissue grafts, looped grafts outperform non-looped grafts. Non-irradiated grafts perform better than those with high-dose irradiation. Furthermore, those undergoing more than 8 freeze-thaw cycles had lower strength. Greater graft diameter was associated with increased load to failure, and grafts from donors over age 40, and particularly age 65 years, have poor mechanical properties. Here are our references. We thank you for watching our video.